Hi, my name's Sophie Nelson. I'm a GP with a special interest in gastroenterology, working at Manchester Royal Infirmary, and I'm here with Simon Smale.
I'm Simon Smale. I'm a gastroenterologist at Manchester Royal Infirmary, and I have an interest in functional GI disease.
This conversation is specifically about irritable bowel syndrome. There is a separate session on diarrhoea and alternative causes of diarrhoea, but we felt it was quite important to bring irritable bowel syndrome out as a separate discussion. So Simon, if you can just start off by summarising for us the diagnosis of irritable bowel syndrome.
Yeah. Okay, so it's pretty ABC to start with. So irritable bowel syndrome is characterised by the triad of abdominal pain, often bloating, and change in bowel habit. And that change in bowel habit may be constipation predominant, diarrhoea predominant, or alternating between the two. And that's important to try and define because it obviously influences the treatments that one might choose subsequently. In terms of presentation, obviously first presentations are commonest in younger people. So a new diagnosis of irritable bowel syndrome is less common in people over 50. It does happen occasionally, but it's less common. So in terms of making that diagnosis, if a young person presents with those symptoms of abdominal pain, bloating and change in bowel habit, things you need to think about and look out for is obviously to make sure that it isn't an acute infective illness, to look out for other red flags that might raise alarm in terms of nocturnal symptoms, unexplained weight loss, and a family history of early onset ovarian or colorectal cancer. And by family history, I mean in a first degree relative, either sibling or parent or children, or ovarian cancer, which obviously can cause bloating by virtue of the ascites. Now, unexplained weight loss is literally that. If people have changed their diet or been to the gym lots more or been in lockdown and therefore changed their eating pattern, that is weight loss that can be explained and doesn't merit red flag referral, whereas unexplained weight loss would be, well, I just don't feel like eating, doctor, and I've lost my appetite and therefore lost weight, is typically how that presents.
Do you have an amount of weight that you consider to be significant when we're making referrals based on weight loss?
So I think you'd expect 5% of your body weight. So I do it as a percentage of body weight. So for me, I weigh 90 kilos, shall we say. So if I lost 5 kilos, that would be significant. Whereas for someone who weighs 50 kilos, obviously 5 kilos is too much. And there you're looking at 3 or 4 kilos perhaps. So if people have got no red flags, then obviously one needs to examine the patient. And in terms of examination, you want to examine the abdomen, make sure there are no abdominal masses, and do a rectal examination, make sure that there's no abnormalities. One of the red flags that is and isn't a red flag is rectal bleeding. So approximately 15% of the population in any given year will have an episode of rectal bleeding. And clearly the commonest cause of those episodes are going to be anorectal bleeding, in other words, bleeding either due to hemorrhoids or anal canal damage. And that's typified by bright red rectal bleeding on the tissue paper, whereas rectal bleeding where the blood is mixed with the stools is very different. But nevertheless, rectal bleeding would provoke a referral for further investigations potentially. In terms of other investigations that everybody should have before they're diagnosed with or given a label of irritable bowel syndrome, let's start with the simple full blood count. I think if people have a normal full blood count, that's reassuring, but if people are iron deficient or they're anemic, then that would raise alarm. Now obviously there might be other reasons for that. So in young women, menstrual blood loss is the commonest cause of anemia, but nevertheless you wouldn't ignore it. So that is a cause for concern. A raised CRP might indicate that there's some systemic upset, and that might relate to the bowels, because obviously you can get Crohn's disease or colitis causing a raised CRP, and that would provoke referral, and if it was significantly raised, it might provoke urgent referral, obviously depending upon the patient's symptoms. By significantly raised, I would say more than 20 or 30. And then celiac serology clearly is an important one. Obviously, if people have positive celiac serology, that implies that they might have celiac disease, and therefore they need to be assessed with the potential for referral for treatment in terms of dietary intervention. And then obviously fecal calprotectin, if your calprotectin is more than 250, that implies you've got significant inflammation, and provided that's not gastroenteritis, that also needs investigation.
While we're on the subject of fecal calprotectin, could you take us through the Manchester fecal calprotectin pathway?
Okay, so the fecal calprotectin pathway is aimed at people who are aged less than 50, in whom you don't suspect a cancer, and you think that either IBD or IBS is more likely. So it doesn't negate the need to take a history and examine the patient, but it's essentially a tool to help differentiate people who might have IBD from people who might have IBS. And so one needs to take a history, exclude the red flags that we've already mentioned in terms of a family history of cancer, bleeding, weight loss, and then you request a fecal calprotectin, which is essentially a very sensitive marker for inflammation within the gut. Now, because it's a sensitive marker for inflammation in the gut, it goes up in response to any provoker of inflammation, and that might be gastroenteritis, that might be inflammatory bowel disease, Crohn's or colitis, or it might just be that you've drunk too much alcohol this week, or you've been taking non-steroidals on a regular basis, all of which can raise your fecal calprotectin. So essentially, if one suspects somebody has irritable bowel syndrome or IBD, in order to try and help differentiate and prioritise them, you can then do a calprotectin. If the calprotectin result is less than 100, then it is very likely that their symptoms reflect, in the context of negative celiac serology, and a normal full blood count, it's very likely their symptoms reflect irritable bowel syndrome. In which case we should send them down IBS's likely pathway, treat as per the NICE guidance using, I would usually start with dietetics, and then think about pharmacological intervention, psychological intervention, and think about using any apps like Zemedy and the IBS network to try and support them. And obviously if the symptoms are then ongoing, then I would seek either advice and guidance or a referral. If the fecal calprotectin is between 100 and 250, it may well still be that their symptoms reflect IBS. And often if people have had some kind of insult, like a non-steroidal or alcohol, we would suggest that they stop that insult and then have a repeat calprotectin a fortnight later. If the calprotectin is still between 100 and 250, then provided that their symptoms are obviously ongoing, then one would consider referral to the community gastroenterology service. If the calprotectin is more than 250, then that implies that they've probably got significant inflammation within their gut, and that implies that they need some further investigation. So that merits a referral to the gastroenterology service, where that would be triaged, and they'd either receive an outpatient review or a rapid access colonoscopy. So essentially that's the Manchester calprotectin pathway, but I would encourage people to use calprotectin as a useful investigation to differentiate significant organic pathology from irritable bowel syndrome.
I think it's probably important to mention that our values on the Manchester calprotectin pathway were agreed with the Manchester Foundation Trust laboratory, so the cut-offs are specific to this region. You may find different cut-offs in different areas, and that's just because they're using different assays to test their fecal calprotectin levels.
So having established those tests are negative, then in the context of a classical history of irritable bowel, of abdominal pain, bloating and constipation, and no obvious risk factors for other things, then one needs to try and make a positive diagnosis of irritable bowel syndrome without embarking on a whole host of other investigations that may well be unnecessary. So the NICE guidance states very clearly is people should not undergo unnecessary investigations such as ultrasound of the abdomen, colonoscopy, endoscopy, if they give a clear history suggestive of irritable bowel syndrome and their initial investigations of, as we've suggested, full blood count, CRP or ESR and celiac serology are normal. So it is really important for people to make a positive diagnosis, and it's important for a number of reasons. Firstly, then you can get on and offer some therapeutic interventions, and that may be pharmacology, but it may also be dietetic or psychological interventions or apps and support groups. And it's important from a psychological perspective for the patient, because actually having a positive diagnosis helps people to plan their lives and to come to terms with managing their symptoms, and that's really critical.
Are there any other occasions where you would consider doing some of those other investigations that we've perhaps said that you shouldn't do if it's a classical IBS history?
So if it's a classical IBS history, probably not, but I think one of the things that might provoke further investigation is if people don't respond, or if there is a question about whether they might have some other infective etiology. For example, Giardia can present as an acute diarrheal illness and then it gets better, but people often have ongoing bloating and altered bowel habit, and that can easily be misdiagnosed as a post-infective IBS, so that's a consideration. And then obviously there is an issue if people are getting predominant bloating and diarrhea and potentially belching occurring soon after eating. One has to think about things like small intestinal bacterial overgrowth, and that unfortunately is detectable using a breath test, which is really a secondary care test. It's not available to most GPs.
So if we were to suspect those, we would refer in secondary care to have those investigations done?
Yeah.
Okay.
Yeah. I think you do that probably after you'd initiated initial interventions and they hadn't responded, or if they had any red flags or things that were worrying.
Just thinking about things that can present in a similar way to IBS, bile salt malabsorption, again, would that be a secondary care diagnosis?
Again, that's a secondary care diagnosis. That generally is in people who have predominant diarrhea, and it's often very watery and frequent, and it often gives them nocturnal symptoms. So there are some features of that which are perhaps more suggestive.
So thinking about this person who has classic IBS symptoms, we've done the appropriate investigations and we're satisfied that there's not anything else going on. How would you recommend that we manage this initially in a short primary care consultation?
Okay, so I'd start by asking them a bit about their lifestyle, about their sleep, their exercise habits, and their dietary habits. Usually I just say, what did you eat yesterday? I'd ask them a bit about coffee, alcohol, and chewing gum and fizzy drink intake, because all of those things can exacerbate symptoms. I would make sure they're eating regularly rather than all their calories at the end of the day with 3 pints of beer and some chips. I would then think about lifestyle. Are they sleeping erratically? Are they sleeping well? Do they do any exercise? Good evidence now that exercise is good generally for bowel habit and GI symptoms in this context. And it's managing that delicate balance between stress, sleep and exercise that is a trick which we're all practicing, I guess. And then I'd think about specific psychological intervention, whether there are any obvious triggers. So I have a chap who gets symptoms whenever he has to get on a helicopter, and he gets on a helicopter for work, partly because he gets symptoms because he recognises that many of his colleagues have dropped out of the sky whilst making journeys on helicopters. So he's been to see the psychologist, and that's now much better. Then I'd think about specific pharmacological interventions. They're broadly fall into a number of categories. There are interventions which affect gut motility. So that's things like antispasmodics, things that make the gut go faster, so laxatives and aperients, and things that make the gut go slower, which is things like loperamide or Imodium. I wouldn't use opiates to treat either pain or diarrhea because that leads to a whole host of other problems. So I would try very hard to avoid opiates under almost all circumstances. And then there are things which help address some of the sensitivity in the bowel. So things that manipulate either local sensitivity at the level of the bowel or central sensitivity. So the NICE guidance recommends thinking about tricyclic antidepressants, and says that if that doesn't work, it might be worth considering SSRIs. And then in terms of other interventions, I would always think about going to the IBS Network website and joining the IBS Network. That's the national charity that supports people with IBS. It has lots of resources in terms of a helpline. It has lots of recipes and experts that will help answer people's specific questions. I also think, particularly if people who've got psychological triggers, there's an app called Zemedy, which is particularly good at helping people with the psychosocial aspects of irritable bowel syndrome. Peter Woolwell's got some very helpful voiceovers in that app. So that's a kind of broad brushstroke of the interventions and treatments. If one thinks that there's a specific triggers in diet, then obviously you can refer them to the dietitians, but the other things to think about very briefly is whether they eat lots of brassicas, beans, peas and stoned fruit, because they are relatively high FODMAP foods. But one shouldn't really undergo a specific exclusion diet, such as a FODMAP diet, a lactose-free diet, a wheat-free diet, without the support of an appropriately trained health professional. And generally speaking, that's a dietitian, although access to dietitians can sometimes be a challenge, I recognise.
So if we're talking about referrals from primary care into secondary care, firstly, who would you want to see out of these patients? And secondly, how would we refer into specific IBS clinics?
So I think we should see the patients where there is, first of all, a question about whether the diagnosis is right. Secondly, patients who have had initial standard therapy as per IBS guidance from NICE, who have perhaps tried dietetics and some pharmacological intervention, and where that's largely unaffected their symptoms, but in whom their symptoms are significantly impacting their lives. So I don't think we necessarily need to see people who are getting symptoms, for 5 minutes once a week, because actually I don't think that's a good use of our resource. But if people's work or personal lives are being impacted by their symptoms, I think that we should see them, because we may be able to help manage their symptoms better, and that improves their quality of life. And because these are young, economically productive people, I think that's really important from a societal but also from an individual perspective. And then I think that in terms of ways into the system, I think a generic referral to the gastroenterologist will be triaged, and it will be triaged to ideally one of the luminal, and then probably beyond that one of the functional gastroenterologists, of whom there are several. So there's obviously myself, but there's also a world expertise at Wythenshawe with Peter Warwell and Dipesh Vasant, who run an excellent and super specialist functional GI service which takes referrals from across the country.
People ask about irritable bowel syndrome and probiotics. Is there any evidence behind probiotics? Can you tell us a bit more about the microbiome?
Okay, so I'll start with the microbiome because that's kind of where the physiology starts. So the small bowel is largely free from bacteria. So if you look at the ileal fluid, it's got 1,000 bugs per mil roughly. Jejunal, probably 100 bugs per mil. But once you get into the cecum, you're looking at perhaps 10 billion bugs per mil. And so there are roughly 10 trillion bugs in your colon, and those bugs influence from childhood the development of your central nervous system, your immune regulation, your metabolic state, and your likelihood of getting diabetes, amongst other things. And so there's a clear recognition that your microbiome influences the diseases, and particularly in terms of bowels, the symptoms that you get, and changes in your microbiome may manifest changes in your symptoms. In terms of specific treatments that address that, obviously antibiotics are a potential mischief, because when you have antibiotics you reduce dramatically the number of species within your gut, and they may actually provoke irritable bowel sometimes. And then one thinks about how can one enhance one's microbiome. Unfortunately, lots of the things which are prebiotics, in other words, things that encourage the diversity of the microbiome, are actually things which are FODMAPs, and so may cause more bloating and more fermentation. And so there's a bit of a paradox there. And interestingly, the FODMAP diet reduces the diversity of your microbiome. So it might not be such a good thing in the long term. Who knows? And then one thinks about probiotics, which are specific species of bugs which may have positive effects. And there are certainly some strains which have been shown and demonstrated to have positive effects on people with symptomatic IBS. And some of those strains would be VSL3 or Alpha X, and there's a bug called marketed under the name of Zenflor, which has been demonstrated to increase resilience in people with anxiety, and they've demonstrated neurological correlates with that on fMRI, which is quite interesting. So in general, the effects of a probiotic are specific to that particular probiotic, and I would suggest to patients they take a probiotic which is generally of high quality and contains at least 1 billion bugs, because otherwise there aren't enough bugs, and that's known to get to the colon, that they take it for at least 10 days, because any bug will take at least 10 days to become established in your gut, and that if it works, they continue it. Usually I'd say trial it for a month, and if it hasn't worked, it's not going to work. And it has to be remembered that a bug will probably dwindle in its numbers within a few weeks of you stopping it. So unfortunately you have to keep paying for them, and they're currently not available on prescription, although that may change. They are in Europe, interestingly.
Does it matter whether that comes as a yogurt drink, whether it comes as a sachet, whether it comes as a tablet, or are they all? Is it down to the bug itself?
So they are. So the effects of probiotics are strain specific. So, for example, 1 or 2 bifidobacteria strains have been demonstrated to reduce levels of TNF alpha, and have been demonstrated to increase the ability of people to tolerate distension within their gut. So they put a balloon up your bottom and see how much they can inflate the balloon. So that's a very strain specific thing. In terms of how you take them, it probably doesn't matter, but usually the yogurty things and the like don't have enough bacteria in them to make an impact on your wider microbiome, and so you need to be taking billions of these things. So Yakult, for example, a Yakult yogurt I think contains about 150 million bacteria. So you'd need to be taking at least 10 Yakults a day to really make a difference. That's a lot of Yakult. And so you need to select a strain which has got enough bugs in it to be making a difference. And it needs to be a strain that gets to the colon, because lots of them die in the stomach.
Thank you, Simon. And that concludes our brief overview of irritable bowel syndrome. All the gastroenterology and hepatology pathways for Manchester CCG are available on the Gastro and Hepatology homepage. The website address for this is up in front of you at the moment.